have to come back again. So if you would like to start and tell us, is the podium on, your name, and you're with the Y?
Absolutely. Hello,
Okay,
I'm
go.
Lauren Kuntz. I am Executive Vice President with the YMCA of Metro Atlanta, and I am just here to share a few things around the health work that we're doing, some of the outreach work that we're doing that you may not be aware of, that we want to make you aware of. You do have a deck in front of you, and I'm just going to hit some high points and then focus on a few slides in the back. I am talking about the YMCA of Metro Atlanta, but my colleague, Carrie Bugos, who is our State Alliance Director, she works with all of our executive directors at YMCAs across the state of Georgia. So the things you're going to hear me talk about today are really things that are happening at Ys across the state as well. Here in Atlanta, we reach about 250,000 people through YMCA programs every year. About 1 in 4 youth and teens and families who come to the Y cannot afford to be at the Y without financial assistance. We raise $6 million a year here in Metro Atlanta to give out for scholarships. We never turn anyone away from a YMCA for inability to pay. And so that is very much in keeping with being a 501c3 nonprofit. We are the oldest nonprofit in Atlanta. We are celebrating 160 years of serving the Metro Atlanta community. We started as a railroad YMCA in 1858. So just all sorts of community service days and things we'll be doing with all sorts of partners across the city to celebrate 160 years. One page that I do think is important, it's the third page in. This is really a snapshot. We talk a lot about at the YMCA. People really don't know what the Y does unless you are participating in a piece of that. In Metro Atlanta, we really live in 4 key areas, one of which is critical to the work that you all do, but we are the largest provider of early learning in the state of Georgia. We provide early learning for low-income, at-risk children, 3,400 kids. We serve 4,000 kids in our after-school programs every single day. Again, 60% of those kids are in Title I schools. We do teen leadership and volunteer leadership development in all of the communities that we're a part of. And then, of course, wellness is integral to everything we do at the Y. If you flip past the next page, you can just really see how far-reaching the scope of our organization is, kind of the breadth and depth and scope and scale of the full facility YMCAs, but also our youth development centers, our resident camps, and the other sites that I mentioned around early learning and after school. There is a page that just has a sampling of many of the partnerships that we have. This is certainly not limited to this, just a few to draw your attention to. If you head to the page that says the Y's mission, Empower Healthy Living, the YMCA of Metro Atlanta is actually the only organization in the United States that has 4 research to practice programs designated by National Institute for Health. And those programs are our Start for Life program, which is a wellness, a research-based wellness program for early learners. Our Youth Fit for Life, which is a wellness-based program for our after-school participants. And then 2 programs for adults, the Coach Approach and Weight Loss for Life. We touch about 160,000 people each year through wellness programming alone. And then as you look at the other next 3 pages, really just the ensuring school readiness, the improving academic achievement, and the inspiring civic leadership. Those are all the programs that I alluded to, but each one of those has a wellness component. What I'd like to touch on, if you skip back to hunger relief, there are 3 specific programs that we are working with all of our branches around Metro Atlanta and across the state right now. One is hunger relief. The Y did not decide to get into the hunger relief business because it was something that we thought was a core strength. But when you work with a lot of children like we do, you get into the hunger relief business when you see that there's a need. So in 2017, we provided over 200,000 meals across Metro Atlanta in partnership with other nonprofits and corporations. We do that in a variety of ways. One is the backpack program, that after-school program that I mentioned earlier. We send children home with unmarked backpacks on Fridays for food for their family, and they can bring those back on Monday, and then they get them the next week. We also do outreach during summer and winter camps. So when kids are out of school and we know that they're not eating, we go to low-income apartment complexes and extended stay motels and provide activities and food for kids. And then we also run food pantries at a lot of our YMCAs across Metro Atlanta. The next signature program that I want you to be aware of is we've had a deep relationship with the foster care with DFACS over the years. And we partnered something last year called the Crisis Card, where children that were aging out of the system could come to a YMCA and receive a crisis card, which was a prepaid debit card where they could go and get shelter or food. So they had some options to be safe and not on the street. One of the things that we are looking at as an association very seriously is providing a free YMCA membership to every foster child in Metro Atlanta. This is a membership that would follow a child, and a family that has the child could also use it. This could be a consistent and safe place no matter how often a child is moved, and would allow them to have access to programs like early learning, after school, teen leadership, day in resident camp, all sorts of things. And then the last program that I would draw your attention to is obviously something that we're all struggling to get our arms around, and that's the opioid crisis. We've been working with the Georgia Prevention Project to empower our teens in our communities to learn how to be advocates and educate their peers in the school system and in their communities to know more about opioid abuse and to speak out against it. So just a very high level overview of some of the things that we're doing, and I hope that I was able to capture that in a brief amount of time, but thank you so much for letting us share with you today.
You did a great job. I will have to say that I did not know the why. You did so much. I thank you for that community involvement.
Thank you. Thank you for your support.
I
We
would have
appreciate it.
something I want you to take back to
Okay.
whoever runs the program on addiction with the opioids.
Absolutely.
National Families in Action used to do a program for after-school children about the brain and what drugs do to the brain. And the kids would dissect a mouse brain. And it was a huge learning thing, and the kids loved it. That program has been disbanded now, but the person is here. I would love to see that instituted back in, because we need to start at a younger age. And it really was very effective. So I can put whoever needs to in touch with
Absolutely.
Sue Rushi,
Yes.
that ran that program, was one of the first to deal with addiction in this state many, many years ago. And if you'll let me know, I'll put you in touch with her. And I wonder if we couldn't revive that, at least try it and see what you think.
Thank you very much.
So.
Madam Chair, thank you again, members of the committee, for allowing us to speak. And again, as Lauren had mentioned, these are programs, most of these programs are instituted statewide. They're not limited to Metro Atlanta, but Metro Atlanta is leading the charge. So, and I'll connect with you about,
Okay.
Thank you. Thank you again.
Thank you very much, and thank you for respecting our time. And I'm so sorry, this is twice that you've been.
Happy to come back.
Okay. Thank you. Okay, let's start with House Bill 782, the governor's floor leader, which means y'all can be as mean to him as you want to. Go at it. Either place, Trey. So, Representative Rhodes.
Please go easy. Please.
Picking on some of you.
No, Madam Chair, members of the committee, thank y'all so much for letting me bring before you House Bill 782, referencing LC 337182.
It's in your folders. Everybody got it?
Yes, ma'am. Do y'all have the bill? Okay. HB 782 is an agency bill that includes several measures that make the PDMP that is so hard for a country boy to say. Y'all understand me? PDMP program easier to use for healthcare providers and help reduce the opioid related deaths in the state of Georgia. First, this legislation allows the Department of Public Health to share data in the prescription drug monitoring program with PDMPs in other states and law enforcement in other states when they have a subpoena or a search warrant. We feel this will better protect Georgians that are living in the counties that border other states. This bill also allows the department to share data with the electronic health records. Providers will be able to log into their EHR to view the prescription information for their patient instead of having to log into both their EHR and their PDMP. And finally, this bill includes cleanup language to simplify the registration process for delegates who are checking the PDMP on behalf of prescribers. The registration process for nurses and unlicensed delegates are burdensome under the existing statute. Unlike prescribers and dispensers, these delegates are required to register twice, first with the Board of Pharmacy and then with DPH. If 82 is passed, these delegates would just have to follow the same registration process through the Department of Public Health that is required for prescribers and dispensers. And then if you want to look at the bill and look at the lines that are added and struck, basically these changes that we made for the law enforcement from other states and search warrant and subpoena languages in lines 20 and 21. And the PDMPs operated by other states is in lines 62 and 63, and that also includes the EHR language.
Is that it?
And then the cleanup language, if you want to know for only having to register once instead of twice, not with the Board of Pharmacy, that is taken care of in lines 32 through 43.
But even though that's cleanup for the people besides the physicians who register, they still have their own identification. Right,
I believe so.
they do.
Yes, ma'am.
Okay, for the committee, so that should somebody misuse any of the information from the PDMP, it's under the doctor, but they have their own identifying, it's not a number, apparently there's a way that they know who's logging into it, and therefore they could identify who did it. There was an incident.
Just not in two places.
Yeah, there was an incident over the past years, one incident where a nurse looked up something and shared it with the front office, and it got out, and they are pursuing that and prosecuting that, which is in the basic bill, that there's a fine that goes along with that. So that's still in there. Okay, questions for the representative?
And if they're too hard, I've got David Bain and Commissioner O'Neill here.
Okay. Where's Commissioner O'Neill? Stand up. Thank you very much for trying, and almost to the point that this is up totally, and making it much more friendly for the physicians and their staffs to use, Dr. O'Neill. So the other one was very cumbersome. Do you happen to know how we're doing as far as doctor sign up, dentist sign up? Close?
We're getting very close. As of the numbers last week, the physicians were over 80% signed up. We had some prescriber groups that were as high as 92%. So we're getting very, very close.
Okay. Thank you. Apparently, there were some physicians that, they said, I've got a DEA number, but I never prescribe anything, and thought they didn't have to sign up. So the rule is, if you have a DEA number, you, nurse, whatever, you've got to sign up, correct?
Correct.
Okay, thank you for all the work. Your assistant, who's in charge of the program? Stand up, so,
Sheila Pierce.
okay? And you're the one we contact if we have any questions about it, right? Okay, anything you want to add to how it's working or gonna work, or?
Things are working fine. I think the cleanup legislation will make things more efficient, and as Dr. O'Neill said, we're well along the way in getting all of the prescribers signed up.
Okay, and it goes into effect on July?
July the 1st, 2018.
Okay, we got it. We're moving there. Can we have your name again and your phone number?
Sheila Pierce,
She-
P-I-E-R-C-E, and my number is 404-463-0772. And if you're a prescriber or a dispenser and need to contact us about registration, that number is 404-463-1517.
Okay. Did everybody get it? They wanted the number and the contact number. If any of your constituents have a problem, or if you have questions about their need to sign up. Okay?
And Madam Chair, if anyone forgets that number, they can always go through the Commissioner's office. We can connect immediately with Sheila.
Okay. Thank you very much.
I haven't signed up.
Huh? Have you signed up?
Yes, ma'am. I'm signed up. Been signed up.
Well, I have a nurse's license, but I don't have a DEA number, so I don't have to sign up. All right. There's.
Get you one.
No, thank you very much.
We can fix that.
I don't want to. Okay. Pardon? Okay, great. So that's
Make a
used.
motion?
Are we ready?
Make a motion, do pass.
Okay. Okay, we've got a motion to do pass in a second. Is there any further discussion? Okay. Yes, sir?
As for a clarification, I thought I had it clarified outside, but the way I'm reading this, these people don't have to be licensed or registered anywhere. The people in the physician's office under 5A, I understand trying to get rid of the duplicative registration, but then they're not required anywhere else in the bill to actually be licensed or registered. As I read it, now maybe I'm reading it wrong, but I want to be sure we have them licensed or registered because the physician is responsible criminally and civilly if these people
Well, they access through his number, but they have their own identifying number. And if I remember correctly, there's a $100,000 fine if you misuse the PDM, the information that you gain. And the reason they're not licensed, Representative, is, and Dr. O'Neill, if you need to speak up on this, the reason that it doesn't require licensure is because for some doctors in small rural areas, they don't have a registered nurse or a nurse practitioner or a PA. They might have an LPN that they would have a license, or they just might have an assistant that doesn't have a license, or a front office person that's going to check it.
All right, and I guess then the other thing I didn't see is where those individuals are. It's a number 5 under they can the plan, the PDMP can provide that information to them, but there's no place in there that says they have to be registered with the PDMP. As I read it.
Dr. O'Neill, or
Sheila, you want to respond?
Only that the only way anyone can look up information, patient information in the PDMP is to be registered in the PDMP. So these unlicensed delegates, in order to register, would have to provide their first, last name, last four of social, date of birth, and then the prescriber that they will be working with will be required to approve them before they will be allowed to search patient information.
Okay, so that's in regulation then, is that?
In the statute.
It is, okay, I'm not seeing where it says in here they are required to be licensed with the PDMP.
Not licensed, but registered in the PDMP.
Registered.
To look up patient information.
But we took annual registration out also. And I don't see where it says they must be registered or licensed anywhere, unless that was a department.
No, I agree, they're not required to be licensed under the language that's in it now. They would have to have someone's authorization to get into it, so.
But they wouldn't have to be registered according to this, is that correct, with the PDMP?
I believe that's correct.
Okay.
You have to be registered in the PDMP in order to log into it, to use the system, so that you can retrieve any patient prescription information from the system.
You could, and in line 40,
okay,
Dr. Newton points out, maybe if we put line 40 through 43 back in, that would have those individuals registered then. But taking line 40 through 43 out, I guess.
okay, Betsy's looking.
Okay, thank you.
Yeah, I mean, even if you were to restore those lines, that code section actually exempts agents or employees of authorized users. So it's my understanding they would be operating under the registration of someone else, but it would allow, in my reading, a staff member that didn't have any kind of medical background to access it, through the authorization of their employer.
All right, but then they would register under the authorization of the physician, when actually it's not the physician that's going in, and since the physician is civilly and criminally liable, I wonder if they should be registered separately, as these people are saying. It,
Okay, Anna, with the Hospital Association, I'm getting a text up here that you can answer this
I can
question.
maybe clear this up. So, Representative Harden, thank you. I'm Anna Adams with the Georgia Hospital Association. So I worked on this legislation last year, and I have over the past several years, and this bill is definitely necessary as far as cleaning this up to make it easier for physicians to be compliant. This section where it strikes the language at the bottom is only applying to those individuals which are allowed to receive information from the prescription drug monitoring program. So when it strikes that language down at the bottom, it's just taking out the requirement that that delegate would no longer have to be a licensed, like a nurse or help me think of other licensed.
PA,
things
LPN.
like that. Yeah.
no,
so
no, excuse me, if I could, while
sir.
you're right there, if I
Yes,
could
sir.
ask this.
Mhm.
It says that if you took out the ones that said they have to be licensed or registered, but left in number 4, which said they must submit to an annual registration process to the department, then that would accomplish what the department is saying, and it would not make them be dual licensed or registered anywhere.
I'm not sure what this section 161335 is, if that references the pharmacy board or if that is referencing,
No, pharmacy
The
board would be in
PDP.
26.
okay. Okay. But to Sheila's point, you cannot access the prescription drug monitoring program until you've signed up for it. And so that's not really a license, it's more of a registration with the program.
And that's
sir.
what that section says.
Yes, sir.
Maybe if we just put it back in, it would.
Betsy's saying that's not what he says.
Well, that section, that code section, the 161335, is the registration section, but it exempts out of that requirement employees and agents of others that are registered. So it wouldn't, it's sort of it's a wash, basically. If you put it back in, they still don't have to be registered because they're exempt as an agent or employee that's designated.
But they would only have to be registered with the PDMP, is that correct?
Yes, I'm pretty sure.
But as it is now, they don't have to be registered with PDMP. They simply have to use the physician's number to get into it.
Okay, Mrs. Pierce?
They should use the physician number. The benefit of having the licensed and the unlicensed delegates would be to allow those who work in the medical practice with the prescriber access to the system so that they can assist the prescriber in obtaining the information as they see patients here and there.
Mrs. Pierce?
Yes, ma'am.
Is there any problem if we pull this bill and go back and add that they have to be, that they must be registered under their,
And so when you say registered, you mean with some entity, some organization outside of registering?
no,
No.
with you, that we just make it required with you?
What you're doing already.
You already got
You're
a password.
required.
I agree.
Okay.
Did you read? I mean,
All right.
that's-
And the only reason I'm letting this go on is because we need to have Bill start moving, and this is very important. So we can get this PDMP, or I would just, go back to the other. Betsy?
I'm just looking at the language of the bill. It would not require in this bill anyone to register. I don't know what the practical process is to access the PDMP, but right now it would allow somebody on the staff of a physician to access it without being a nurse or a PA or any of the others that are under here, a pharmacist.
And the word access means to log into the system. And the only way that you can log into the system is to have an approved registration. And so you log in and you are approved, but part of that process is for the prescriber that you're working for, whose patient's records you will be reviewing. That person has to approve as supervisor you're gaining access. But no one can gain access without our checking, again, the information, first and last name, last four social, date of birth, and the approval of the supervisor or the prescriber that you will work under in obtaining medical records.
But Mrs. Pierce, did you say that, and I'm not trying to put you on the spot, could some physician give somebody in their office their number and let their registration number or code or whatever, however it works, and could they go in without themselves, gaining their own identification?
I mean, you have your email address and a personal password that you set up yourself. So if you give your password and your email address to someone to access the system, I mean, I would imagine it could happen. But the goal is that each person, and the attorney is saying that's illegal, and that would be wrong for any system that has security measures associated with it. So here, the purpose is to allow those who work in the medical practice with the prescriber to
I got
gain
you.
authority appropriately to enter the system so that they can retrieve the records to assist the prescriber in their medical treatment program for patients.
Okay,
Madam Chair, could I propose something?
yes.
Down, if you look on lines 54 to 57, that is some parallel provision that talks about individuals in healthcare facilities. And at the end, it says, so long as the medical director of such healthcare facility has authorized the particular individual for such access. What if we put a similar provision, not the medical director, but so long as the physician has authorized the particular individuals for such access? So it wouldn't just be any.
Well, prescriber, because you got physicians doing this.
Right.
Yeah.
Yeah, prescribers
Just
or
put
dispensers
prescriber.
staff.
Will that cover it, that they would have to have their own identification number and could only use that?
Well, if that's existing law, so I'm assuming that's working, so I would have to defer to.
All right, prescriber or dispenser, I believe, is the language used in the rest of the chapter. That,
So long as the prescriber or dispenser has authorized the particular individual for such access.
I still would like to see them have to have their own registration number. But you're saying you'll know who's entering, even though it's under the physician's number?
No.
Their own number.
No, they wouldn't know.
You just said you'd
She's
like
still
to see
doing
them
this.
have their own registration.
Yeah. All right.
Technically, they have their own registration.
Okay, so you are doing what is struck out in here anyway. Line 40 through 43 is struck, but you are doing that anyway.
Okay,
Okay.
all right. Trey, I'm gonna pull the bill. I'm gonna work with Betsy to make this clear. We'll run it by y'all to make sure we're not messing up anything. I'll see you back next Tuesday. This bill is important. I don't believe it'll get hung up on the last moving part. I will go to leadership if necessary.
Yes,
To
ma'am.
tell them that we need to make this clear.
Absolutely.
And
Thank you.
that we don't have any other questions.
Thank you.
Anna, can
Yes,
you
ma'am.
be in on helping us?
Absolutely. Thank you.
And so I guess I'll see y'all in my office before Thursday. Okay, please. Just call my secretary, make an appointment, and Anna will come whenever y'all can come. And hopefully Betsy will be available and we can work this out. Thank you very much. Thank you, Representative,
Thank you, Madam
for your
Chair.
input. I know that you are just trying to make sure that the people who pull this off take responsibility for their actions.
Exactly.
And that, I also don't want a physician having somebody in their office do something and that person not being identified. So we'll work this out. Okay. And moving on. Let's see, where are we? Representative Silcox. Where'd you go? Oh, there you are.
She says, "Hey, we should disapprove."
It's 6:36. Okay. Okay. Hello, ladies. Nice to see you again.
Madam Chair, thank you so much.
Okay, committee, listen up. This is something new for you.
I'm bringing to you all today House Bill 636. And this is a bill that talks about genetic counselors. And I'd like to introduce two genetic counselors who are our guests today. Katie Long, who's on the staff at Northside Hospital as a genetic counselor, and Andrea Paul, who's with Quest Diagnostics as a genetic counselor. This bill would provide for licensure of genetic counselors. I'm sure that y'all have seen the ads, as I have, on television, on the internet, to get your genome done for no money, right? And increasingly, the cost of this has gone down. And unfortunately, with the cost going down and more people trying to get information about this, it has caused a lot of fraudulent information about genetics to be disseminated by people that are not authorized and not educated enough to give out that information. And so that is why we're bringing this bill. And I'm going to let Katie and Andrea tell you all more about genetic counseling.
Thank you so much. Thank you, Madam Chair and members of the committee, for having us here today. My name is Katie Lang, and I'm here with Andrea to give you some background about genetic counselors. We know it's very common for people to not fully understand what genetic counselors exactly do and how we're trained and our educational background. So I'd love to fill you in on some of those details. So I myself have an undergraduate degree in something called Integrated Science and Technology from James Madison in Virginia, and then I went on to get a master's at Johns Hopkins in biotechnology, and then a second master's in genetic counseling, finally, at Virginia Commonwealth University in Richmond, Virginia. And after that, I did a cancer genetics fellowship at Georgetown. So most genetic counselors do have master's degree, well, really all genetic counselors have master's degrees from accredited genetic counseling training programs. And there is an accrediting body that accredits those training programs and make sure they meet the rigorous standards for training. That is called the ACGC. And that's been around for a very long time. So once you go to your accredited training program, you then graduate and pass a standardized national board exam. That is yet another acronym, the ABGC, that issues that board exam. So the credentials that we use are MS, standing for Masters of Science, and then CGC, which is Certified Genetic Counselor. So that's how you know a person has done all of those things, because we have MSCGC after our name. A master's degree is the terminal degree in our field. There is no such thing as a PhD in genetic counseling yet. Maybe there will be in the future. So if you're master's trained, that's sort of as far as you can go. You can get a PhD in something else, but it wouldn't further you in the field of genetic counseling. What we do is basically help people understand how genetics play a role in the development of different diseases. Genetics is basically infiltrating every area of medicine. Testing has expanded dramatically. There are literally thousands of genetic tests that can be ordered by licensed providers. Yet, ironically, we are not licensed providers, so that's what we're trying to do is enable, title protection and the ability to order these tests that we are so, trained in. And also, I think I don't know if it's in the materials you gave, but last summer we went before the Georgia Occupational Regulatory Review Council and were approved. So GORC agreed that we should be licensed. Andrea and I met with them, and it was a wonderful meeting. They asked great questions, and we were very pleased that at the end they agreed that licensure is important for our profession. And Georgia would be the 25th state in the country to pursue licensure for genetic counseling. Basically every other state except 2 who have not achieved licensure are currently working on it. So it's definitely a nationwide effort that's going on to achieve licensure for this field. And I'm going to hand it over to Andrea for some more information.
Sure, thank you. So good afternoon. My name is Andrea Paul, and I'm also a board-certified genetic counselor. I'm currently working at Quest Diagnostics as a field-based genetic counselor. I received my Bachelor of Science from Purdue University in biology. Took 2 years off to figure out what I wanted to do, and then went and got my master's in medical genetics at the University of Cincinnati. I graduated in 2010 and now work at Quest Diagnostics in an industry-based role. Prior to that, I was seeing patients full-time at both Emory and also Wellstar in clinic, and I saw patients independently. So I wanted to share a little bit about what my role entailed when I did see patients in clinic, and then compare that to sort of what I'm doing now in an industry-based position. When I was in clinic, and I spent about 5 years seeing patients, we received patient referrals from a variety of healthcare providers, whether it was a breast surgeon or an oncologist, or my specialty, of course, was oncology. And the patients would come to see us, and we would spend anywhere from about an hour to an hour and a half with our patients doing what we called a really comprehensive risk assessment. So that included talking to the patient about their personal history of cancer, if there was a personal history, as well as assessing their family history of cancer and what relatives had previously been diagnosed with cancer, how they were related to the patient sitting in front of me, what cancers they had been diagnosed with, the age of diagnosis, and et cetera. We took all that information into context and were able to provide the patient with a risk assessment and made some decisions with the patient in terms of, did they qualify for testing? Did they meet certain national criteria that are established to determine who should be offered testing? And then determine what test is really the best for that patient. What test encompasses all the genes that are associated with the cancers we're seeing in that family to give us the best opportunity to catch a mutation if there is one to be found. We would then see the patient back a couple weeks later after their test results came in and counsel them about the results. So was it abnormal? Did we find a gene mutation that is responsible for the cancer we're seeing in that patient's family? Or was the test result normal? And sometimes additional testing was needed in that scenario. After disclosing the results, we would talk to the patient about what they could do next. So if they did test positive and we did find a mutation, we would need to discuss sort of what they're going to do with that information. So the idea of having genetic testing can really be very empowering if you're appropriately counseled about how to use those results. And so a big part of our job is to appropriately counsel those patients so that they know how to use their genetic information to take action and reduce their risk for cancer in the case of the patients I saw. What I do now, so that was my clinical role. What I do now with Quest Diagnostics is work in a field-based role, specializing in the education of healthcare providers. So I travel really throughout the Southeast. I am based here in Atlanta. I live in Atlanta, but my role is really throughout the Southeast. I cover 10 states. I travel around. I meet with healthcare providers, and I essentially teach them how to do what I used to do for my patients. So how to identify patients who are high risk for hereditary cancer syndrome, how to disclose those results, how to identify if a test is positive or negative, and then what to tell the patients afterwards about any surgeries or extra screening they may need to be considering to reduce their risk for cancer. The scariest thing to me is when I am traveling around and I meet individuals who are providing genetic counseling who are not healthcare providers. I have met social workers who are providing genetic counseling. I have met medical assistants who are providing genetic counseling. And I actually met, this is an example from Alabama, but I met a woman who had been diagnosed with breast cancer herself. She was in her 30s, so quite young. She had genetic testing and had kind of gone through the genetic counseling process. And her employer had now employed her as a genetic counselor because she had personal experience with a diagnosis and receiving genetic counseling, and that was her experience. Essentially, her training was her personal experience, and she provides genetic counseling in Birmingham. So that's the scariest thing to me is when I know the training that Katie and I have and the training that our colleagues have to really provide exceptional services and high quality health care to our patients. And when we encounter people who are just kind of sticking out a shingle and calling themselves a genetic counselor, it's really scary, and I worry for the patients who are encountering those types of genetic counselors and aren't aware that those individuals are not appropriately trained. Thank you.
Questions from the committee? Okay. Representative Pizzo.
Not on. Oh, there it is. Got a question. Outfits like Helix, like Archives DNA, how do you guys interact with them?
So I actually know the genetic counseling world is very small. So I know several of the genetic counselors who work at Helix. We don't really need to utilize Helix. They are focusing in the what we call the direct-to-consumer genetic testing realm. So direct-to-consumer testing are things like what you see on TV, 23andMe, Ancestry.com, these tests that don't necessarily require a healthcare provider. So we wouldn't necessarily need to utilize something like Helix or some of those companies. But what we do and help the providers do is identify good labs versus people that bought a sequencer with a lot of money and call themselves a lab, because what people don't realize is these tests are not approved by the FDA. There is no one out there besides really genetic counselors or genetics professionals that can vet a lab versus, a highly qualified lab versus anybody else. So there are some very scary stories about people that call themselves a genetic testing lab and can throw up a flashy website. And I'm not saying that Helix is one of those companies, but there are many others, and really can do damage. I mean, misinterpret results, charge patients exorbitant amounts of money that people do not realize they shouldn't be paying. I mean, we encounter these things all the time. So I think a huge thing, because the testing is getting cheaper, as Representative Silcox said, which makes it easier for people to start these companies without anybody kind of overseeing them. And they'll say that they're CAP and CLIA approved. That has nothing to do with being good at genetics. That has to do with having a clean lab and something like that.
So full disclosure, this sounds like a protectionism bill to me. It sounds like what we're doing is trying to protect the existing genetic counselors, in light of it getting cheaper and it becoming more accessible to people. That's my only concern, which is basically a concern with the whole thing, but that's all.
Okay, Representative Newton.
Chair, I was along the same lines, whether ancestry or paternity, and I see these signs, a lot of places, and obviously with this bill, Representative Silcox, would this change those? Would it put them out of business? Would it require them to partner with a approved? Or are they exempted somehow because all they're doing is paternity or ancestry?
Right, and really it comes down to, do you require medical help? If you're just researching your ancestry or your paternity, then they don't have to be affected by this. They will not be affected by this at all. This is really if you have a medical situation where you have a history of breast cancer in your family, you have a baby that's born with some genetic abnormalities, or you have unknown cardiac risk in your family that are discovered through an incident or accident in your family. So this is not applying at all to those companies. This would not affect them.
And also, this bill is not to say we are the only people allowed to order genetic testing. That is not what we are saying at all. Any licensed provider right now can order genetic testing, and that would not change with this bill. So physicians, anybody out there who is providing genetic services to their patients, this will remain unchanged. All we want to do is also be able to order genetic testing and be licensed ourselves, because we feel we have the adequate training.
Answer your questions. Okay, Representative Barr.
Thank you. This has been interesting to listen and learn about this, and I have some folks who have been very much helped by y'all. A couple of questions, if I may. Do y'all have an association, and do they have a position on this?
Should I answer? Yeah. So we have a state association. Andrea and I are also on the board of that, for full disclosure, so we support it. Nationally, we're very well supported, and we have heard that the State Medical Association has no concerns about this bill.
Have your membership, have they looked at this and voted to pursue this?
Yes.
And to continue on that, there would be obviously some training. Is that easily accessible in this committee? We've talked about that several times on adding certification hours. Is that something are we going to have to go out of state? Do we provide that? And what would the cost of that be? And do y'all already do that? Sorry, there's a lot of questions, but.
Yeah. Do you want me to? So we already need continuing education to maintain our board certification. So this is just incorporating the training that we already receive. So Andrea and I help host a meeting in Georgia every year that will do that, no matter what. So we have national meetings. So we maintain our CEUs. This is just incorporating our normal continuing education that we already are doing to keep up our board certification. There wouldn't be anything additional.
Gotcha. And will this enhance your ability for insurance purposes? Forgive me, I'm not a medical professional, so I ask some dumb questions at times.
In other states, it has shown to improve reimbursement for our services. It has shown it helps with credentialing at hospitals, so it helps hospitals attract genetic counselors and maintain genetic counselors, because right now without a license, we can't be individually credentialed. You have to be underneath a physician. So it does help with things like that, yes.
Okay, thank you. Thank you, Madam Chair.
Okay. Our state has been pretty lax on who we let do certain procedures. I think when you listen to these ladies about their education level, I would say that most of you in this room would have really perhaps some trouble, unless you were biology graduate students, of understanding genetics and the complications and being well versed in them. So it's not exactly something that the average person chooses for a profession or really understands. And where the problem lies is that people that want to set out there and call themselves a genetic counselor when it's a medical issue. I will tell you that I watched two boys grow up on my cul-de-sac. They married, and the younger one had a little baby girl. And I didn't want to go to the hospital, so I wanted to give the grandmother the baby gift, and I saw them coming in to their driveway, and I went bounding out with the baby gift, and the grandmother opened her door and fell into my arms in just absolutely hysterical crying. They had just been told that Sophie had basically a Swiss cheese brain from a genetic problem. And the doctor had told them, and doctors are very busy. This one was a very caring doctor, but did not have the time to spend a lot of time with them or bring somebody in that could work through this with them. And they were at a total loss because they had been told they didn't know whether the child would ever walk or ever talk or ever be able to sit up, that it just had to wait until whatever happened. Well, I'll tell you that Sophie is a 7-year-old in school doing just fine, and after traveling all over the country to the leading experts on this illness, they think it was a misdiagnosis. Doctors are wonderful, and I am a real person who is a champion for the physicians and what they do, but they don't know everything, and they have to rely sometimes on the experts in pathology and other areas. And this, with more and more areas of medicine becoming known, and especially the brain, I think that this is not all of the physician's specialty, and especially when it comes to genetics and sitting down and counseling and dealing with the emotional trauma that this occurs when somebody is told that their child has severe problems. I think what we're trying to do with this bill, and we did it with our lactation specialist, we said we need to set a higher standard for the people that are going to do this kind of work, and that there are certain educational requirements and experience that you need before you sit down with families and go into such delicate process with them. So this is, you see my name is on the first one on this bill. I'm the one that went to the Bork committee and told these ladies that Bork would not pass it out, that it would be turned down, and almost fainted when the people on the Bork commission said, yes, this is a needed bill. I mean, really, I had told them, just be prepared for it not to pass. And and was floored myself. So this is how this has sort of evolved. I have lots of things to do, so I asked Representative Silcox to carry this bill, and that's sort of where we are. So do we have a motion on the bill?
Move to pass.
We've got a move to pass. Do I have a second? Okay. Is there any further discussion from the committee? Okay, Representative Price.
Okay, I'm not prepared to vote on this as yet,
Well, you may abstain.
but I do have some questions if that's appropriate.
Yes.
Okay, the ladies who have presented here today, can you reiterate your your training? I know you referred to having patience, and I was trying to figure out what that meant. And are you in the position of making diagnoses, or are you in a position of referring back to the recommending physician, what your findings are based on the genetics?
The latter. So we are sent patients by physicians. So I work at Northside, I work at the Cancer Institute. So as Andrea said, surgeons, oncologists refer patients to us who they suspect may have a hereditary predisposition. We target the genetics piece. So we help them understand how likely or unlikely it is that there could be a hereditary component to the cancer in their family, or that they may have been diagnosed with, help them decide whether they want genetic testing. Do you want this type of information? Here are all the implications for you, for your family. As Chairman Cooper said, it's a very niche type of discussion. So we spend 90 minutes with every patient focusing on the risk assessment as far as the cancers, the ages, the genes we're suspicious of, and explain to the patient what would happen if we did find a mutation in one of those genes, what would happen if it was negative. There's also a chance of getting an inconclusive result, and then all of that goes back to their medical provider when they're done. So we basically meet with people twice, what we call the pre and post-test
Okay, so
counseling.
you're generally, excuse me, but you're generally asked to ascertain a specific question.
Yes, so we handle basically genetic testing, and then they go back to their physician with this additional information, and their physician takes over their care and handles it from there.
What concerns me is if you have the blanket ability to order tests, and if you get reimbursed for those tests that are ordered, what's preventing you from ordering like everything in the world? And then the next thing you've got the ethical dilemma of what do you tell the patient and what do you not tell the patient? And furthermore, does this have an impact on insurance for things like pre-existing conditions?
That's excellent.
I mean, I feel like
Yeah.
we have to be more restraining in what in a physician-patient relationship, what then gets done so as not to open up a can of worms.
Sure. So one part of that I want to address, the tests are third party. So they are not run at Northside. They are not run in-house. So we have the financial relationship between their insurance company and the lab is what the testing reimbursement is. It has no bearing on my pay or
Currently.
anything like that. Or even with this. I mean, this would not change anything to do with how the testing is always going to be ordered through a third-party lab with the physician involved and us involved if they've been.
Did you not say earlier that this was going to allow you to order tests?
It would allow us to order tests, but and it would be case-by-case basis. We would always prefer there's a physician involved, but we're saying with licensure that we feel that we have the genetics expertise to be able to order genetic testing appropriately, because that is what our master's degrees are training us for. Yeah.
I just want to add to that you can't go around ordering genetic testing willy-nilly. There are national guidelines for who meets certain criteria and should have certain types of genetic testing or should be offered these types of genetic testing. And there are insurance companies and these different NCCN, for example, that the test won't get covered, it won't get run if you don't meet certain criteria. So when we're meeting with the patient for an hour to an hour and a half, we're asking questions to ascertain, do they meet the criteria to have the test in the first place? So the only instance where we would order a test is if we know really it's going to be covered because the patient meets criteria.
Yeah, so even if we order a test, it doesn't mean it gets run. The insurance company still steps in and decides to cover it or not, and then if the lab isn't going to get paid, they don't run the test. So there's multiple sort of layers. But I can speak for where I work. The physicians prefer we are the ones ordering the testing. They rely on us to have the genetics expertise component. They still need to be the oncologists and the surgeons and, their training. And we are inundated and overwhelmed with referrals from patients because they see the complexities. They can't answer the insurance questions. They don't know about protections for, you mentioned, can people lose insurance? They cannot, not health insurance, not just because of the Affordable Care Act, but there's a separate law called GINA, the Genetic Information Non-Discrimination Act. And those are things we go over with every patient in our pre-test session. So I think part of the reason that physicians are supporting us in this effort is because they are in the trenches with us and see that this is kind of I always say this is our corner of the world, that we can supplement the care of this patient as far as the genetics component, but they always need their physician to, carry on their care after where our assessment is done and the testing has been ordered. Because I can't send them for a colonoscopy or order a mammogram. They need their physician to do all of that. So we work hand in hand with the physicians.
Representative Henson.
Thank you, Madam Chair. With regard to some of these questions, and it seems like we go through this a lot of times when we're creating a new board to register or to license, that we seem to forget that it is ultimately going to be the board that will promulgate the rules and regs. And we, as legislators, are not supposed to promulgate rules and regs. Also, since this is coming under the Medical Composite Board, won't they be involved also with the oversight of the rules and regs being promulgated?
Yes.
Thank you.
Okay, thank you. Okay, and in relation to that, we need to, Betsy, where we could add that the bill will go into effect upon funding for the medical board. Okay, is there anyone in the audience that would like to speak to the bill? Do we have anybody? Okay, delayed, okay. Give Betsy a second. Got it, Betsy? Okay, an amendment, I'd like to propose an amendment that would read.
So we'll add, this will be on page 7 on the last page of the bill. After line 288, we'll add a code section that's into that article 43-34-307. This article shall become effective upon appropriations by the General Assembly in an Appropriations Act specifying this article.
Okay, so I'm making the motion. Do I have I'm proposing the amendment. Do I have a motion?
Move to approve the article.
Okay, do I have a second? Amendment. Do I have a second?
Second.
Motion is second. Any discussion on that? Everyone in favor say aye. Aye. Everyone opposed, no. Okay, the ayes have it. All right, we have a motion on the floor for the substitute now that we, right, Betsy? That makes it a substitute that will go forward. Substitute to House Bill 636. Everyone in favor of the passage of the substitute to House Bill 636, please say aye.
Aye.
Everyone opposed, say no. Okay, the ayes have it. The bill passes. Okay, thank you, ladies, for that.
Thank you for coming. I appreciate it.
Okay, and, okay, going back, we have now clarified, and I want us to move out. I have clarified the information about 782. In the law, the department is charged with maintaining the integrity and basically secrecy of the information on the PDMP. And under that, they make the rules and regs, and there is a rule that says they must be registered. So that answers your question, like that. So, did we get to a motion on that one before? Can I have a motion on the passage of House Bill, which one is it?
782.
782.
Do pass.
Got to do pass. Do I have a second? All right, I have a motion for passage and a second. Any other further discussion? Okay, everyone in the favor of the passage, say aye. Aye. Anyone opposed? No. All right, that bill now passes. Okay, we have one left. That's House Bill 646. Representative Dempsey is in very extended appropriation bill talks, and so I told her that I would present the bill. In 2009, I believe, we passed the first bill for a pilot project on surgery for the different obesity type surgeries. What this bill does is basically just continue that with another iteration of that type of pilot project for 3 years. I think you have a handout in your in your folders to what, and you can see the states that their plans cover this. The ones where no plan, their state plan doesn't cover it, and the ones that have pilot projects, and then ones that have pending legislation. You will see that it is largely all the states in the country have obesity and bariatric surgery, the correct name, covered in their state health plans. Some background on it: 17% of our country is obese, or 17th according to the CDC. Georgia ranks 17th in obesity, 12th in diabetes, and 11th in hypertension. Obesity cost in the United States is $150 billion a year. In Georgia alone, more than $4.2 billion in obesity attributed expenditures were spent in just 2009. 4.2. 90% of the obesity related medical illness either improve or resolve after following weight loss surgery. And so do you see a significant decrease in the comorbidities such as diabetes, hypertension, sleep apnea, and so forth are reduced. So the plan, we had a report on it this summer, and on the people that had already participated in the state plan, the ones that had been involved had a 67% remission in their diabetes from the surgery. They had a 47% remission in their hypertension. They were thankful and appreciative of the plan and completely satisfied with their life after their surgery. Their claims went down. There was a 76% in congestive heart failure, a 44% in COPD, and a 51% decrease in depression. ER visits decreased by 37%, and also visits to their own physicians decreased by 37%. There was, however, because following the surgery, 11% increase in going to specialists, and that would be because of the follow-ups then go to the bariatric physicians. So what Katie, one of our members who can't be here, and we are asking for is that we continue the program for 3 years. And if you will look at line 21, we need to make some adjustments. On line 21, at the end it says, subject to appropriations. We need to strike that And that is on the recommendation of DCH in that department. On line 22, we would change January the 1st to 2019. On line 22.
Change the 18 to 19.
Uh-huh, to 19. And it is a 3-year pilot project with 100 individuals being allowed to, participate. Okay. Okay. Okay, and on line 83, that date would be changed to 2021. Or it should be really, Betsy, that should be June 30th of 2022.
Right, to give 3 full years.
To give them 3 full years, not 21.
June 30th, 22, give them 6 months.
Right. 83, on line 83, that would be December 15th, or June 30th, 2022. On line 83, June 30th, 2022. And, okay, so that would go to June 30th, 2022. On line 102, June 30th, 2022. Betsy also has language that DCH has requested. DCH feels that they are not the best organization because of staffing and their other responsibilities to collect and analyze the data so that we can make sure that after this 3 years, we have a very exact results on how much this makes a difference and how effective it is and how much it lowers costs. For example, when they said that it had saved the state so much money, the estimate was that it had reduced the people in the program, they had reduced their pharmacy costs by $182 a month or $2,185 a year. But DCH had not extrapolated out of that if they had gone and gotten a prescription for an expensive cream for a rash or something. And so that is the thing that they feel like that Augusta University could do. That's where we have our medical college. That's where we have a lot of researchers. So they would like to insert that in the bill, and Betsy has language.
All right, so on line 23, at the end of that sentence,
Line 23?
right,
Okay, the end of insurance plan?
right. Add a new sentence that reads, "The department shall be authorized to enter into an agreement with a post-secondary institution in the state for pilot program management, data collection, patient engagement, and other activities related to the pilot program."
Thank you. I mean, it didn't specifically say Augusta College, but, I mean, they were thinking that that's where it would go, somewhere that has the medical background and expertise to evaluate the program. So that at the end of 3 years, we have more very realistic, very solid data on what this is, whether this is really effective for our state. Okay. Questions from the committee? Representative Henson.
Thank you, Madam Chair. First, I do support this. I have supported this over many, many years, and I believe it was back when B.J. Walker was head of DCH, way back, that we actually made a decision to cover bariatric surgery under the state health plan. I don't know when or why it was pulled off, but we did cover it. And I happen to be very much in favor of it. My question or two is, couldn't this start in July 1st of 2018 instead of January of 2019? Because we're asking people to wait another year. before they get covered for bariatric surgery. And since we're not asking for a fiscal note here, subject to appropriations, and as you pointed out, bariatric surgery might have a cost, but it eliminates other costs that these folks are currently, being covered for. Also, yeah, okay, and I do wish the pilot program would include more than 100 people.
Okay. You getting this, Andrew? Okay. I'm going to let Andrew with DCH, Andrew Johnson, answer your questions.
Thank you.
Okay, Andrew.
Thank you, Madam Chair, and members of the committee and Representative Henson. My name is Andrew Johnson. I'm a Deputy Commissioner at the Department of Community Health. We have the pleasure of administering the State Health Benefit Plan amongst many other operations that we have there. Specific to your question, the reason it's January 1st is our plan year goes on a calendar year basis rather than a fiscal year. I understand your concern about waiting there, but we would prefer it start January 1, consistent with the plan year.
Then a follow-up, because you change things in the middle of the year constantly, or the insurance folks that we're covered under change things. I might be allowed a drug and all of a sudden walk in one day and find out, gee, it's not covered. This isn't covered. So if y'all can change other things for state employees in the middle of a year while they have a contract, why can't we add this? Because it's only going to affect 100 people.
So it's my hope, and from the plan operations, that our formulary is consistent through the year in your state health plan. I'd be happy to talk with you about some of
Your formulary
those
is not
specific
consistent
things.
throughout the year
Okay.
on the health plans, and that's part of the problem. We have a contract that we have to abide by, but DCH doesn't always feel they have a contract they have to abide by, and that's the contract with us.
I can
But
understand.
again, if we go
Representative
back.
Henson,
Yes,
you're beating a dead horse, which I've already beaten pretty hard in the last week. And over making, about trying to get medicines without people having to fail on them and so forth more than one time if they have critical illnesses that are life-threatening or really interfere with life. So that's another subject. You can help me out if I ever get that bill through. And
I'd be happy to come discuss those with you as well.
thank you
Absolutely.
for the answers to those questions.
No problem at all, and
All
happy
right.
to answer any more questions, Madam Chair.
Okay, I think we've got more. Representative Mosby.
Thank you, Madam Chair. I don't care who.
You want me, either one?
So the pilot project worked well previously, correct?
Yes, sir. We're still analyzing some of the outcome data. So it was 2015 and 2016. Previously, it was a covered benefit from 2009 to 2011. It was, of course, we were in an economic decline at that point, and it was removed. It is a high-cost benefit without question. But without question, I think as some of the data that we've shown is there are some promising outcomes for some, and so I don't want to be dismissive of that from the plan administration side. Yes, we're still analyzing some of the 2015 and 2016 procedure data in the out years.
Were there any cases that you did not cover because of appropriation?
Any cases that we did not cover?
Right.
So the pilot was for 75 in 2015 and 75 in 2016. None that were not covered because of a lack of funding issues. Right. It was all funded within the plan. There was no money added to the plan. It came from within the funding in the plan. There were, I think, 68 or 69 in the first year. A couple of those were folks who opted out of the procedure. There were some who opted out for financial reasons. There's still a copay and coinsurance involved, just like there would be with any other procedure. And a number of those were replaced with folks on a wait list, but a couple of those weren't replaced because they left the pilot very late in the year and couldn't be replaced, but not for lack of appropriations, no, sir.
Right, go ahead.
So in the data that you're currently evaluating, is there something there that's giving you pause from moving forward and to just cover this?
For full plan benefit?
Right.
It's mostly, I will tell you, it's we have some positive indications on the data, but it's more of a cost. At this point, it's more of a cost look. The procedure itself, between 2015 and 2016, there's 3 different types of procedures that are available. The average cost was just under $20,000 per procedure for just the procedure. There are other certainly follow-ups, any sort of complications or anything that may occur otherwise that may contribute to cost increase, but it's been a financial decision at this point to not bring it fully back into the plan just yet. And to Madam Chair's point about our desire to partner if we move forward, if this body chooses to move forward with the pilot, we have very good staff at SHBP, and our clinical folks were doing kind of the data outcome and the data measures and the patient follow-up in addition to their everyday real job that they have. And they did a good job in that, but it was not a true research-based project. We did look at reduction in claims and those sorts of things. It would be our desire, if this body chooses to move forward, that we partner with a higher education institution in this state who can take a better look and a more refined look at a more of an actual research-based approach.
And I think that they will have some longer-term data when they end of this study with the patients that first did it, so we can see more of the long-term effect of what happened to those patients. If the committee remembers, and if you weren't here, there are stringent requirements. They don't let anybody just walk into this. They have to go through, is it 6 months or
There's a significant kind of pre-op
readiness
procedures that I know we spent a lot of time on this summer during the study committee, but folks have to be both mentally and physically ready and indeed financially ready for the procedures in front of them. That's counseling. These had to occur at what's called a centers of excellence, so specific providers who aren't just going to do the procedure and walk away from the patient or not have that, who are going to stay engaged in that follow-up and make sure that they're doing the kind of the out months and out years management and helping that patient essentially with what sometimes feel like their new life.
Right. And, you know, state employees, I didn't know this, typically stay about 9 years. So if we begin to see a real cost saving at 3 and 4 years, we have another 5 extra years to, you know, have the reward of doing the surgery, not counting what it does to their work performance and attendance at work and everything that goes along with it, because these are patients who are morbidly obese and have a high record of missing work and being less effective at work. So it is a very stringent, and not just for somebody that wants to lose 40 pounds. So we have that. Representative Hilton. Okay. Representative Price.
Thank you, Madam Chairman. My concerns are on page 2, lines 55 through 57. I'm concerned that we've specified the procedures that would be covered and maybe inadvertently left a person in a lurch if the procedure got changed, you know, interoperatively. That, for instance, number 2, if laparoscopic turned into an open procedure, and gastric band, as far as I know, is done laparoscopically, and we didn't specify it there. And the Roux-en-Y, boy, oh boy, I don't know who would want that. But, you know, I guess there are people that maybe once it's paid for, that they would much rather do that than something more simple. So I'm not sure that we even need to specify at all that, you know, if we just had, I mean, I don't know what other procedures there are and why we're wanting to narrow it down, or if we could say whatever's FDA approved, or if there's something that we thought we shouldn't be covering. Anyway, I just don't know why we're being so specific as to the actual procedure and maybe boxing ourselves in such that a patient might get a huge bill because there were some intraoperative changes.
Well, Representative, these are the ones that the experts in doing the surgery thought that we should include. And I think when you're doing a study, you have to put the parameters in, and you can't be, you know, changing it in the middle of it. So this is what the department and the experts in this area of bariatric surgery
But
thought we should
again,
include.
you know, about 10% of the time, a laparoscopic procedure turns into a full open procedure. So does that mean it would not be covered?
Of course not.
Well, how do you know?
Well, I mean, if you've got a patient on the table and one thing goes that they're not going to.
No, but
that's
the
a-
law says we're only paying for a laparoscopic procedure.
I can clarify. My understanding, or I do know these are the procedures that were in the initial pilot, and they were described that way the first time. We, to my awareness, didn't have any issues from those. I appreciate your concern, Dr. Price, and I'm not sure of the answer. I know the goal is to get folks into one of those 3 procedures.
And how was the gastric band performed?
I think you'd have to ask a bariatric surgeon, and we don't have one here.
Well, I think it's laparoscopic. That's my point. It's number 2 is specifying laparoscopic, and number 1 is not. So can it be done laparoscopically according to this law?
I
Representative, you know, down here, we have to rely on experts to advise us. You're not a bariatric surgeon. I'm not a
I've been in the
bariatric
operating room during these procedures many times.
surgeon. Well,
And probably not many people in here have, so
I mean, you've given the anesthesia for the procedure.
I'm watching. I know what's going on, yeah.
Right. Well, I think we have to go forward on what's recommended, and this is
Well, I
what-
just don't want someone to not get paid and say, I thought it was covered, and then it's not.
because it went to an open procedure, I think that would be considered a complication, if I'm correct, and we have paid for complications of the surgeries.
Madam Chair, if I may, to that point, we did have some individuals who experienced some very extreme complications, even a few at times, and those were covered under the plan, under the benefit. Some that had some very high cost, which even drove some of the average cost in the pilot up, but they were covered under the plan.
Okay, is there a way to do a gastric band not laparoscopically?
I'm not a
Representative
clinician.
Price, if you have these kind of questions, I think you need to
don't know.
talk to me beforehand, before the meeting, and give us an opportunity to try to reach somebody that's a specialist in this. We're moving on. Representative Bennett.
Thank you, Madam Chair. I just have one question in terms of coverage in the event that there are complications, and thank you for that reference that before in the prior term, all complications were covered. But in line 64 through 67, in the event that there are complications that arise secondary to the procedure, it says that all healthcare services provided pursuant to the pilot program shall be subject to the health insurance carrier's plan of benefits and policy provisions. Does that kind of leave it open, or are we?
So, Representative, thank you for the question. And I think what we're getting to here is about 95%, 95.5% of the folks in the first year, 2 years later, we're still in, as of the end of last year, we're still in the state plan. About 94% of those last year. Some people may leave state employment. This doesn't require you to have to continue to work with the state. We obviously, from a financial perspective, it would be, if they stay in, it's great. If this leads to better outcomes that reduce their healthcare costs in the future. But if they left and were covered under a different plan elsewhere or a potential new employer, it wouldn't be SHBP's responsibility in the out months and years.
Thank you.
Representative Jones. And Representative Dempsey, if you want to step up and say anything as this goes forward, just let us know. Just go.
Thank you, Madam Chair. I would like to say that I support this pilot program. When Dr. Titus Duncan was here before our committee, he did my surgery. I had the laparoscopic procedure done when I was working at Lockheed, and I'm glad to see it as a pilot program here at the state for those that may want to participate in it. I had no problems with my surgery. As of 2 months ago, I went to Dr. Titus Duncan's office again for an additional follow-up. But bringing this program here to the state health plan, I support it.
Thank you. Representative Barr.
Thank you. I just want to clarify, when we're talking about sending this to a study to get an official study done, will we have the access to that to look at that in the future as well?
Yes.
Okay, perfect. And then one more follow-up.
Sure.
Just logistically, if, again, this goes to my ignorance on the medical field, will the 100 individuals in the last year, do they make an impact in the study if we're getting the study at the end of the third year? Just out of curiosity.
So we are continuing. That's one of the reasons we moved the report date out another 6 months, was to allow some time. I will tell you, some of the data that we offered in the summer study committee meeting was actually, and some of the best data we have is actually from when it was a covered benefit from 2009 to 2011, because to your point, indeed, some of the real understanding of the real outcomes are in the later years, and not necessarily in the 6 months or 12 months prior. Indeed, some of the folks that received the procedure in 2016 are barely a year out, and that. So I think to your point, it's there, and we are happy to continue at the committee's will to offer any additional data. I'm open to how we want to look at how long that goes.
Great, thank you.
Representative Barr,
Thank you,
it's the last one listed in the ones that they do that has the most drastic, almost immediate results. I mean, when they do that one, their diabetes is almost instantly solved. And so you see it faster, they lose weight faster. On the other two, it can be a much slower process. And like he said, for the first year, they're still under pretty intensive care. So it really is but we want the data to be right and to share it with this committee before we go forward and hopefully expand this to the whole program rather than just a pilot program. Or either we decide that it wasn't the thing to do and then, give it up. So, but we can only do that on sort of long-term data
Right.
that looks at all the aspects. Like I say, you can't really know if it saved $182 a month if you didn't study which medicines they were on and take out all of those that had nothing to do with any comorbidity or illness that they had. Like I say, might have been a salve because they got a rash on there, and it was a $40, or and they used it 4 months, and that skews the point. And so we really want it done in a more academic, sound study. So.
Thank you.
I'm amenable to looking at the date for the report, or maybe subsequent reports if that's what's desired by the committee. So
Would
that's
love
some
to
work
have them
that-
as you get more of the patients that are in the program now. I think our committee would love to have an update on those patients.
And to be candid, I think the university partnership, if this pilot moves forward, would help us and be a little bit easier for us to continue to watch that data.
Okay. Representative Henson.
Thank you, Madam Chair. If we go back to one of the biggest concerns that I've heard out there this year from constituents is the whole concept of surprise billing, of going in, having been told what it's going to cost,
Okay.
and then getting that.
Representative Henson,
Can I-
that's a whole nother.
I know, but because of lines 64 through 67, I'm concerned that could happen when coupled with the specifics on 55 through 57. So can we just put something in to, since it's state health, to just ensure that the patient doesn't get a surprise billing?
I don't think we can do that with contracts that have been offered by the.
So it's the state health benefits plan, of course. Well, let me suggest this: when a individual leaves employment with the state, they can continue their coverage under the state health benefit plan. Okay, they can continue even if they're under 65, not Medicare eligible. They can leave at potentially, and maybe if they have less than 10 years. Maybe at an unsubsidized rate, but they can stay active if they paid the full premium. So they could actually stay in the plan and might have an incentive to do so in a scenario in which you mentioned. If they were covered under another health plan, I would suggest that the state shouldn't be responsible for for costs that may continue even as a result of this elective procedure. It is an
If they're
elective
covered
procedure.
under, now, I just wanted it so people under the state health plan would not get the surprise billing, that if we could put in some protection there for state employees.
Okay,
So we
That are
have,
covered under the state health plan.
Hey, y'all, thank you. First of all, thank you for everybody for understanding where we are in the budget process. And I'm so sorry I couldn't be here because this bill means very much to me and to people that I care about. And that's what I think we all have to remember at the end of the day, is that this is about helping people. And we're here to do that. I think what you're talking about, Representative Henson, is going to be covered in some other legislation, but specific to the state health billing program. If we fixed it there, it wouldn't fix, if we attempted to fix it there, I'll say, it wouldn't necessarily do that for any other places. So as far as the surprise issue, I think we're going to hear more about that, but not in this. Anything we can do to keep this as pure and clean as we talk about bills should be, I think will help it. Because it's a hard discussion, but it is one that I think is very important to Georgians' overall health.
Thank you.
Okay. Representative Hatchett.
The appropriate time, Chairman, I'd love to make a motion.
Oh, thank you. I would love for you too. Representative Bennett, are you just got a really burning? This is the last one.
A birdie, yes, ma'am. Thank you, Madam Chair. I really do appreciate this bill. I've had personal affiliations with people who've done it. It's done great things, but particularly because of my interest in decreasing diabetes and the benefit that it has for comorbidities. Thank you, Madam Chair.
Anna, do you have burning things to say?
We support.
Okay. All right. Let's have a motion.
Move to pass.
Okay. Okay, I have a motion to do pass, and I've got a second. We have amendments to offer. Do we need to go through them again? They're the ones that change the dates, that take out upon appropriation, and that put it with a university system in. Can we have a motion on that? Move on the amendments. Is an amendment. Do I have a second? Everybody in favor of the amendment, say aye. Aye. Anyone opposed, no? Okay, now back to the motion. Is there any other discussion? Don't push your button. No. Okay, so everyone in favor of the passage of the substitute to House Bill 646, say aye. Aye. Anyone opposed? No. The ayes have it. And with that, we are adjourned. Thank you very much for your Tolerance Committee members and for being here.